I'm going to talk about diabetic ketoacidosis. Now guys, the slides which are in blue color, okay, meaning I have a diagram for those slides. This slide basically is what I have written down in this slide. Does that make sense? Okay, so I have taken the writing of these slides and I have converted it into a diagram, because diagram is visual, it's easy to understand, and it will be much more easier for you even if you have to write it in your exams. Okay, so now as I said, we are talking about the other complication in a diabetic individual, acute complication, which is called as ketoacidosis. All right, so both conditions, hyperglycemia as well as hypoglycemia, can produce ketoacidosis. How? We'll look at the mechanisms. All right, so in a hypoglycemic individual, all right, what happens? In a hypoglycemic individual, how does this result in hypoglycemia first? Okay, and therefore ketoacidosis. So when does hypoglycemia happen? When you have less food intake and you may have high insulin or high oral hypoglycemic agents, which is the medication which type 2 diabetic individual are prescribed, such as metformin, for them to regulate their blood sugar levels, for their pancreas to be more activated so that they release sufficient amount of insulin. Okay, so these are called as oral hypoglycemic agents. Okay, so this OHGH, OHGA is oral hypoglycemic agents. All right, so when you have less food intake, but as this happens especially when a individual is newly diagnosed with type 1 diabetic, and they may accidentally take more insulin than required, and their food intake is less compared to the insulin which is taken, or their food intake may be normal, but they have accidentally taken double dose of insulin, okay, or the wrong type of insulin. All right, so yes, and in a type 2 individual, as I said, type 2 individual, they may have taken greater amount of oral hypoglycemic agents complemented with less food. Okay, or else even in type 2 diabetic individuals, if their blood sugar levels are very, very high and they are suffering from complication, they are also put on insulin. Okay, so they may have both of these things. They may have insulin as well as they may have oral hypoglycemic agents. Okay, so then what is happening? Then you have basically what happens, because you have so much of insulin in the blood, you have so much of oral hypoglycemic agent triggering endogenous production of insulin. Okay, so you have high insulin or you have high glucose, which is going inside your cell. Okay, because of the high insulin, because of the high oral hypoglycemic agents, you have high amount of glucose which is going inside your cell. So inside the cell, you have high glucose, but in the blood, you have low glucose. So this is essentially called as hypoglycemia. Okay, so you have low blood sugar levels. All right, then what happens, as you know, whenever you have hypoglycemia, you can only have so much amount of glycogenolysis, meaning glycogen being converted to glucose. Okay, there is only so much that can happen. Then what will happen? Then you have fat which is broken down for energy. So yes, fat undergoes beta oxidation. It will give you energy, which is your ATP. But remember, dealing with fat is like making a deal with the devil, because fat will give you ketone bodies. Okay, so now when you have ketone bodies being produced, this leads to high ketoacidosis. Now this is how hypoglycemia results in high ketoacidosis. Does that make sense? Is this very clear? It's very simple. If you see, the mechanisms are very simple, but because a lot of you may be learning it for the first time, so you will need to go through these mechanisms a couple of times, and then they'll become like the back of your hand. They become really easy. Okay, because see, it's the best thing about pathophysiological mechanisms is that you don't have to memorize them. You have to understand them. The more you understand them, guys, the easier they will be for you, and you will be able to retain them for a long run. Okay, moving to hyperglycemia. Okay, so now how hyperglycemia leads to ketoacidosis is what we are trying to cover over here. So now with hyperglycemia, it's the again, it's the opposite thing, which is you have high amount of food intake. Okay, so you have taken, you have eaten a lot of food, but you have taken less insulin, or else you have forgotten to take your oral hypoglycemic agent medication. Okay, so you had, say, a big dinner, or else you had a big lunch, but you forgot to take your insulin dose, or else you have taken accidentally a lower dose of insulin, or else you forgot to take your medication. Okay, so now what happens? You have high glucose in the blood. Okay, so you have a lot of glucose which is floating in your blood. Yeah, this is my floating action. Okay, so you have a lot of glucose which is floating in your blood, which cannot enter the cell. Okay, why it cannot enter the cell is because you don't have any insulin. Okay, and because you forgot to take your medicine, or else you took a less dose of your medicine or less dose of your insulin, you don't have a lot of insulin to bind to the insulin receptor complex, so the glucose can go in the cell. Okay, there is no insulin, and you know insulin is the only carrier for glucose. Okay, so yes, in the cell you will have less glucose. Okay, but you will have a lot of blood sugar levels in your blood. Okay, but what is the use? All right, you know your ATP cycle, metabolic cycles cannot take place in the blood, right? You don't have the TCA cycle happening in the blood. TCA cycles happens in the mitochondria. Mitochondria is one of the organelle systems of your cell. All right. Does that make sense? This is how, guys, this is how you need to remember things. Why do I remember these things? Is because I always backtrack it. Okay. So like why low blood sugar levels are in the cell, not low blood sugar levels in the blood, but why low glucose levels in the cell is scary, because you will not have the TCA cycle happening, because the TCA cycle happens in the mitochondria, which is part of the cell. Okay, so even if there is so much of glucose in the blood, it's of no use to me if I don't have enough insulin, because I cannot use up that glucose. Okay, so yes, you have hyperglycemia. You have hyperglycemia, but your cells are starving. It's such an irony, right? So you have so much of resources, but you still have the cells which are starving. Okay. So sometimes I think of this as developed versus developing countries. Like in developed countries, you have so much of food wastage in developed countries. Like for instance, like, you know, you may have a lot of plate waste going on, but then you have on the same planet Earth, you have developing countries where people are dying of starvation. Okay, like in Ethiopia, like in, say, many rural villages and tribal communities in India, people are dying of starvation, but on the same planet Earth, you have so much of wastage which is going on, right? So same irony is existing in your body. You have so much of sugar in the blood, but you have hardly any in the cell, and therefore your cells are starving. Because your cells are starving, fat is broken down for energy, which gives you ATP via beta oxidation. Of course, then you have ketone bodies which are released. Ketone bodies meaning ketoacidosis, and therefore hyperglycemia also results in ketoacidosis. Does that make sense? Okay. So guys, in this simplistic manner, it is not explained in the textbooks. It is not explained in the research article. When I make these diagrams, I have read 10 textbooks, 10 research articles, taken the latest evidence and summarized it, collated it in form of these diagrams, in form of these flowcharts. Okay. That's why if you see these lectures are so unique, because it's not a copy paste of any textbook or a research article. All right. Okay, so guys, again, these are blue color slides. Blue color slides meaning there is a diagram following it. Okay, so now I'm going to explain you two concepts, Dawn phenomena and Somogyi effect. Remember for now that Dawn phenomena and Somogyi effect, this is very likely, and the prevalence of Dawn phenomena and Somogyi effect is much more in a type 1 individual rather than a type 2 individual. It's not that you don't see it in a type 2 individual, but in a type 2 individual, you still have some insulin production. There is still some natural management of glucose happening, but in a type 1 individual who is completely dependent on external insulin, that is where you see the concepts of Dawn phenomena and Somogyi effect. Okay. So now we'll go into the differences for the same. So Dawn phenomena and Somogyi effect. So now, basically, in dawn phenomena, during the pre-dawn time. Okay, so what is pre-dawn? It is between 2 a.m. to 3 a.m. Okay, so when it is 2 a.m. to 3 a.m., what is it that you see? You see hyperglycemia. Okay, in dawn phenomena, between 2 a.m. to 3 a.m. at night. Okay, so like in the morning basically, but we are sleeping at that time. Okay, generally normal people. All right, so yes, at night, 2 a.m. to 3 a.m., you will see that the individual has hyperglycemia. Okay, but in Somogyi effect, between 2 a.m. to 3 a.m., generally speaking, you see hypoglycemia. Okay, so that is where this especially happens in the early stages of type 1 diabetes, when the individual is still trying to learn and trying to identify their insulin dosage and insulin response. Okay, so when they are still trying to set into a pattern as to what insulin dosage will be best for them, that is when they generally say this. Therefore, the doctors will, their GPs will ask the individual to wake up between 2 a.m. to 3 a.m. and test their blood sugar levels, because that will help to differentiate whether the individual is suffering from dawn phenomena or whether the individual is suffering from Somogyi effect. And depending upon what they are suffering from, their insulin to food ratio will then be adjusted for. All right, because at the end, if you see, at 8 a.m. in the morning, okay, at 8 a.m. in the morning, both in dawn phenomena and in Somogyi effect, the individual will see hyperglycemia. Okay, the reason for hyperglycemia is different, and we'll be covering that. But remember, if you were just to wake up in the morning and check your blood sugar level, okay, a type 1 individual, and then they see, oh, they are suffering from hyperglycemia, they may get worried that, oh, this happened because I didn't take enough amount of insulin at night, I will take more amount of insulin at night. No, it's not as simple as that. Okay, but basically in the morning you will only see hyperglycemia. But this hyperglycemia, is it because of Somogyi effect or dawn effect, is what the GP will try to identify, and therefore the GP will ask the patient to wake up at between 2 a.m. and 3 a.m. Okay, so all right, so what happens in dawn phenomena? All right, in a type 1 individual, generally, yes, you have eaten the right types and amounts of food. Okay, but you have taken very less insulin, or else you forgot to take your insulin dose. All right, so you have eaten food, but you don't have sufficient amount of insulin with it. Okay, and in a type 2 individual, if this is seen, then yes, you have eaten food, but you forgot to take your medication, or else your endogenous production of insulin is very less, and the medicines which you have taken is also very less. It's not sufficient to trigger enough amount of endogenous production of insulin. All right, so you may have either forgotten to take your medicines, or else you took very less dose of it, or else if type 2 individual are on insulin and medication management, maybe they forgot to take their insulin or took only one of each. Basically, at the end, the conclusion is the insulin factor, medication factor is less, and therefore the sugar level is high in the blood. So when they wake up between 2 a.m. to 3 a.m., they see hyperglycemia. There is a lot of glucose which is there in the blood floating, okay, but not enough of insulin. All right, there is a lot of glucose which is floating in the blood, and therefore when they wake up in the morning, what they see is you have hyperglycemia, but this is secondary to external glucose. Okay, secondary to external glucose, meaning you have eaten so much, there is so much of glucose which is coming from the diet. Okay, but you don't have sufficient amount of insulin or medication. All right, so that is the condition. Now what is happening in Somogyi effect? Somogyi effect, when you have a type 1 individual, they have not eaten sufficiently, or else they ate sufficiently, but they took more amount of insulin. Remember, type 1 individual, as I said, generally this is seen during the early stages, meaning they are still learning to adjust their doses, and they may have accidentally done some mistakes. Okay, so they took more amount of insulin, but they only ate the regular amount what they are eating, or else they ate much more less than that. Okay, all right. So yes, so they have taken more insulin. Over here, it's the opposite. More insulin, but less food. All right. And in type 2 individual, what happened? Yes, you may have skipped a meal, or else you did not eat sufficiently, something like that. But then you have your endogenous production of insulin which is happening, all right, and plus maybe you have even taken your oral hypoglycemic agent, which, see guys, over here, which I have not written over here, okay. But yes, in this individual, they may have skipped a meal, they may have eaten very less, but they have endogenous production of insulin, plus it is complemented with the medication, or else if they are on an insulin regimen, they may have taken the insulin as well. So over here, basically what is happening, the insulin component is high, the glucose component is low, okay. So yes, you have less glucose, but you have high insulin in the blood, all right. So whenever you have high insulin in the blood, what will the insulin do? It will take up all of that glucose and it will throw it in the cell, okay. So yes, now your cell have metabolized all of that glucose, but now your blood is starving of glucose. It's the opposite thing. Now the blood is starving of glucose, okay. Firstly, the blood is less in glucose because firstly, it may be that you haven't eaten enough, okay, or else you did eat enough, but you took so much amount of insulin, so much amount of medication, that all of that glucose has been transported into your cell long ago. It's been metabolized, and now we are again on square one, which is your blood is starving of glucose, okay. So then what happens? You know that hypoglycemia is something that the body does not like. You need to maintain your nutrient levels in the blood. So your body will not tolerate hypoglycemia, okay? But remember, this hypoglycemia is because you had lots of insulin, less glucose in the food, okay? So less glucose basically. All right, so then what happens? Then the internal metabolic cycles will start triggering in the cell, meaning you will have glycolysis, okay, and to give you glucose, which is thrown in the blood, you will have endogenous production of glucose, all right. You will have gluconeogenesis. This NEO, neo is gluconeogenesis. So you'll have protein and fat which are converted into glucose. So your blood glucose levels can be maintained. Therefore, you will have high glucose in the blood. But remember, this glucose in the blood now was produced because of internal production of glucose, okay. It was not because your diet was high in glucose. No, it was because in the night time you had internal production of glucose because of the metabolic cycles. Therefore, now when you're waking up, you are having high amount of glucose in the blood, okay. Whereas over here, hyperglycemia is because of external glucose, because of the food which you have eaten, but less amount of insulin. Over here, hyperglycemia is because of internal glucose, meaning high amount of glucose which is produced in your cells in your body to combat the hypoglycemia which you experienced in the early morning times, okay. So therefore, what would be the management? The management in dawn phenomena for type 1 diabetes, as I said, it starts with less insulin, right? So the main thing over here is to manage the insulin and the food ratio, okay? So firstly, to eat sufficient amount, not to eat less amount, all right? And the type of insulin may be managed, meaning you may have long-lasting insulin taken at night time. So there is gradual flow of insulin in the blood, okay. But very importantly, you cannot not eat. So there is the food which is eaten is fine, but the insulin dosage over here is essentially managed, meaning, for example, long lasting insulin provided at night time, okay. So in type 2 diabetic individual, what is managed is carbohydrate loading throughout your meal, which is carbohydrate counting or carbohydrate loading, which I'll not go into the details of, and taking sufficient amount of medications with the food. Okay, so over here, remember, the management all depends upon this little box over here, which is over here, you need to regulate your insulin dosage. For instance, long-lasting insulin taken at night time, all right? And over here in type 2 diabetic individual, you need to take sufficient amount of medications, okay? So you need to do this, all right? So now when we come on to the Somogyi effect, what needs to be done is, firstly, over here, the issue was that you were not eating enough, okay? In most of the cases, that is what happens. So yes, the first thing is, please eat, okay? In Somogyi effect, please eat, all right? And then you need to manage your insulin dosage with what you eat. Yes. And yes, if you are when you're eating enough, you will need to have your medications, your oral hypoglycemic agents, or else it would be just the endogenous production of insulin if the diabetes is maintained well. That depends. And remember, a lot of type 1 diabetic management and even type 2 diabetic management in some instance is done with the diabetic educator. All right, but diabetic educator plays a very, very important role in managing the insulin doses with the carbohydrate loading that the dietitian would do. Carbohydrate loading, the dietitian would say XYZ amount of carbohydrate throughout the day. The diabetic educator would manage the insulin throughout the day for the diabetic individual and the type of insulin as well. So diabetic educator and the diabetes dietitian, they work very closely together. Okay. So I hope this is clear, Dawn phenomena and Somogyi effect.